Hey guys, video is recorded on July 24th. What we're going to talk about today is anterior uveitis. Okay, it's also known as iridocyclitis, and I like the term iridocyclitis because it's more informative. Okay, the word irido and the word cyc and the word itis, okay, tells you that it is the combined inflammation of the ciliary body, okay, and the iris, right? So as it's stated here, inflammation of the iris and ciliary body. Now this inflammation can either be an acute condition or it can be chronic. That means long-standing iridocyclitis. Now you must understand, when it's acute, the symptoms are more marked, and as it progresses, or as it enters chronicity, there are minimal symptoms. So we are again concerned more in the acute stage, and that's what we're going to talk about first. We will discuss the symptoms in detail, right? So the clinical feature, we talk about the symptoms first, where, as you can see, pain is the first and most important feature, redness, and then lacrimation. So how I see this, these are all signs of inflammation, right? Your dolo, your calor, right? And I take lacrimation as your tumor. Okay, so swelling giving you lacrimation, that's how I always see it. Okay, now pain, first of all, it is dull aching type of pain, okay, having a throbbing sensation. Okay, this pain is everywhere your trigeminal nerve supply. Okay, so normally it's in the forehead and scalp region very commonly. Okay, so your pain you get in this region. Now the redness here is because of histamine and histamine-like substances and the toxins. Now all these histamine and histamine-like substances, they are released because there is an obviously inflammation. So what do they do is dilatation of vessels resulting in active hyperemia. So that hyperemia gives the color of redness, right? Then lacrimation is because of lacrimatory reflex. Now this reflex is controlled by afferent and efferent, obviously. Afferent and efferents. Okay, so the afferent is normally the trigeminal nerve, okay, fifth nerve. So whenever this trigeminal nerve gets irritated, you get the efferent giving you lacrimation. That is your seventh nerve, your facial nerve. Okay, so afferent and efferent. Okay, next is defective vision, photophobia, and blepharospasm. Okay, now defective vision is very interesting. Now early on you only get slight blurring, but over time when it becomes more worse, there is marked deterioration, and it is because of what we're going to see are the signs. See, all these are the signs which we will discuss. That means these signs would result in defective vision. Okay, we'll discuss all of this, so I'm not going through them right now. Photophobia and blepharospasm is again that same reflex controlled by the fifth afferent and seventh efferent nerve. So normally this seventh nerve efferent supplies the orbicularis oculi muscle. So when the fifth nerve is irritated, what happens? The orbicularis oculi muscle goes into blepharospasm. Okay, contraction. Okay, clear? simple symptoms, the signs of inflammation first, that is your dolor, calor, rubor, okay, pain, redness, lacrimation, that's how I remember it. And then there is defective vision, photophobia, and blepharospasm. Okay, then moving on into the signs. So these are the signs. Now I've arranged them accordingly. Starts off at the lid, right? Then moving on to the conjunctiva, to the cornea, then the anterior chamber, the iris, right? Then the pupil, lens, and vitreous. So we're going to see each of these signs in detail. Okay, so I've just enumerated them to make it easier, but we're going to see each of them in detail. So the lid first, it will be edematous. Okay, now the reason, basically there's an inflammation, so there is dilatation, right, due to the histamine, right? It's just body's method to bring in more blood, right? So to fight off whatever inflammation present there, right? That's the idea you have to have. Okay, so it's bringing in more blood. So what happens to the lid becomes edematous. Again, more blood means there would be congestion also, you must remember. So there would be circumcorneal congestion. Now it's marked early on in the acute and then becomes lesser when it's in chronic. Again, now corneal signs, the cornea, as I told you again, it's the edema. Okay, corneal edema is the same idea. The eye is trying to fight the inflammation, right? Triggered by, yes, early on histamines. There's dilatation, bringing in more blood. Okay, so that gives rise to the edema also. That's the idea. Now so this is not the most important corneal sign, corneal edema. Rather than that, what's more important is PEEPS, Theoretic precipitates. This is most important, okay, because it can tell you whether the iridocyclitis is a granulomatous type of iridocyclitis, non-granulomatous type of iridocyclitis. So it can tell you the pathology or the cause of it. Okay, clear? Now, so the KPs, what are they? Theoretic precipitates. They are basically proteins, okay, that are normally deposited behind cornea. Okay, and how they are deposited, if you can look, there is in this triangular manner. Okay, so triangular fashion. Now there are few types of theoretic precipitates. I mean, it's not just one type. Mutton fat theoretic precipitate. Just remember this: granular theoretic precipitate, red theoretic precipitate, old theoretic precipitate. Now the word mutton fat is very important because it tells you the consistency of the theoretic precipitate. But before that, I'll just go in order. Now this is normally seen in a granulomatous type of iridocyclitis. That means inflammation of the iris and ciliary body due to a granulomatous infection. Okay, now this granulomatous infection can either be TB, it can either be syphilis, can be brucellosis. Okay, so in these conditions, right, it even can be a foreign body. Okay, so in these conditions, what are you going to get is the mutton fat theoretic precipitate. So that itself will tell you, right, if you understand what conditions you get a granulomatous infection, you'll understand what is this mutton, or what composes this mutton fat theoretic precipitate. See, macrophages, right? You get macrophages, and if the macrophages fail over time, you get what? Epithelioid cells, and this is what makes up the theoretic precipitate. As I told you, next is the consistency. So the word mutton fat, that's how I remember it. It is fluffy, it is latticeous, large, and thick. Okay, now it's lesser in number when you compare to this granular keratic precipitates where there is hundreds of them. Now these granular keratic precipitates are seen in non-granular uveitis, right? And they are made up of lymphocytes. They are basically dirty white and discrete and small, so many, giving you endothelial dusting, literally like dust, appearance of dust there. Red keratic precipitates are normally seen in hemorrhagic type of uveitis, okay, and inflammation where there is hemorrhage. So mainly it's inflammatory cells and RBC, the keratic precipitate. Okay, and then you also have posterior corneal opacity. So these are the three corneal signs: corneal edema, keratic precipitate, posterior corneal opacity. Okay, so we talked about keratic. So this is mutton fat keratic precipitates. Can you see the triangular arrangement of it? Looks like cotton balls, so you can think of it as fluffy, ladicious, not much, few in number. Then you move on. So we talked about the lid first, right? Okay, I'll try to draw. We talked about the lid. Then we talked about the conjunctival layer. Now we're talking about the corneal layer. We spoke about corneal, so then move in one step into the chamber, anterior chamber. Okay, so what are you going to see in the anterior chamber? So in the anterior chamber, first two things you're going to see: aqueous cells and aqueous flare. Okay, well, the two things you're going to see are aqueous cells and aqueous flare. Now these aqueous cells you can identify it by slit lamp examination. The aqueous flare is also by slit lamp examination. Basically what happens, right, the blood vessels get damaged, and because they get damaged, they leak out protein particles into the aqueous humor that give rise to the flare. Okay, it looks like this, you can see. Okay, right, that's how it will look like. Now these two are important. So in the chamber you're going to see aqueous cells and aqueous flare. Besides that, you also get hyphema. Hyphema is what? Simply blood in the anterior chamber. Hypopion. So hyphema is basically just blood in the anterior chamber. Hypopion, they are exudates in lower part of anterior chamber. So if this anterior chamber, normally this exudate is very thick, so thick whitish in color, so they normally sink down. Okay, do I have a picture? No, I don't. Okay, right, so this is hypopion. Clear? Done. Then you move on to iris signs. Okay, so we speak about the iris now. Okay, very interesting. First and foremost, because the iris is extremely edematous and waterlogged, the pattern of it is lost. So first thing you're going to say, loss of normal pattern. So I'm just talking about the active phase. Okay, then it appears muddy in color. Okay, so these are important. Okay, because of the edema and the waterlogging of the iris, normal pattern is lost, color is muddy. Okay, that is fine. Okay, first two things. Then these two things are very important: iris nodules and posterior synechiae. Now first of all, what are these nodules? See, iris nodules are normally seen in granulomatous type of uveitis. Basically what are they? They are just the macrophages forming the epithelioid cells that go on to form the giant cells that becomes these nodules. Okay, these are the nodules, right? Then so basic component of it is macrophages forming the giant cells. Two types there: Busaka and Copace nodule. Very important. See, this picture is also fine. So Copace are normally near the collarette and Copace is at the pupillary border. This is better, this picture. So here you normally get the collarette, you get normally Busaka's nodule, and at the pupillary zone or the margin here you get Copace nodule. Okay, how I remember normally is the piece in Copace tells me that is in the pupillary border. Okay, that is number one. Number two, there is Synecke. Very, very important. Now, what is Synecke? Synecke is basically adhesions. So when I say posterior Synecke, the adhesion is between, let's say if this is iris, this is my lens. Okay, I'm going to draw that lens. Okay, iris and lens. So if you can see, there's adhesion between the posterior surface of iris and anterior capsule of your lens. Okay, so posterior surface of iris, anterior capsule of lens. Now why is there this adhesion? Why do you get the adhesion? Is because what happens to your exudates, right? They start organizing. Okay, so when they start organizing, that means, you know, they start organizing here, causing the adhesion. Now there are three types you need to know: segmental, annular, also known as ring Synecke, and total posterior Synecke. Now segmental, that means, let's try to draw it. Let's say if this is my lens. Okay, I'm trying to draw my lens here, and I'm trying, this is my iris. Okay, so it is only at this my iris I'm trying to draw at certain parts only, at some points only. Okay, can you see? That means there is adhesion here, here, and here. So at some points. Now this is very, very important because this can lead to festooned pupil. Okay, there is a picture here. There, this flower shaped thingy. Okay, why? We'll talk about it a little bit later. But you note, a segmental posterior Synecke can lead to festooned pupil. Now annular ring, that means here I'm drawing here, this is my lens and I'm trying to draw my iris. So complete iris, can draw iris like this, is stuck. Okay, so now because completely it's adhered to the anterior capsule, what happens is whatever that's behind the iris, that means here, right, these are your posterior chamber, in front is anterior chamber, right? So whatever fluid that is in the posterior chamber, right, cannot flow towards to the anterior chamber, which is the normal flow, right, posterior chamber to anterior chamber. So what happens, right, over time is that there is formation of this thing. The fluid keeps forming, it starts pushing the iris forward. This is called iris bomb formation. Okay, clear? Now, very important term you need to know is seclusio pupillae. That is when there is annular posterior Synecke, right? That means there is no circulation from the posterior chamber to the anterior chamber. That is called seclusio pupillae. Okay, I repeat once more, seclusio pupillae is when aqueous cannot flow from posterior chamber to anterior chamber because of a ring Synecke. Okay, clear about it? And total posterior Synecke, that means totally, that means this whole iris, whole posterior part of iris, so I'm drawing that one now, side view, so the whole iris adheres. So this one doesn't give rise to iris bomb and all because the whole thing adheres. Okay, clear? Next. Okay, so the nodules, if you can see that this is Busaka nodules, important, right? As you can see, they are the colorate. Copace nodules, as you can see, they are the pupillary margin. Okay, clear? And also one more iris sign that is left out here, neovascularization of iris takes place. Okay, that's again a way of body to heal, right? So that's called rubeosis iridis. Then moving on to pupillary signs, very important also. Again, iris signs, pupil signs, very, very important. First of all, what's going to happen? Your iris is edematous, right? They are extremely edematous. So what's going to happen to your pupil? They become narrow. Number two, this any pupillary reaction, they also become sluggish. Okay, so pupillary reaction becomes sluggish. The reason again is the edema and hyperemia of iris. So what happens? It doesn't react, movement of it decreases, right? Of the iris decreases, so the pupillary reaction becomes sluggish. That is fine. Now, irregular pupil shape. This is the festooned pupil I'm talking about. Festooned pupil, which is due to, as said here, segmental posterior synecdoche. Now, see, this is at segments only. Now, what happens when you give atropine? There is further dilatation of the pupil, right? That means this parts here, right, further dilates, or further moves back. So that's when it gives you this shape. Okay, clear? Festooned pupil. And can you see the segmental posterior synecdoche here? Okay, so that is important. Next, ectropion pupillae and occlusio pupillae are important. Ectropion is eversion of pupillary margin. There's a picture, I think. Yeah, as you can see, it's everted out. Okay, I don't know whether you can, this is everted out. Okay, why do you get this eversion? Is because there is the fibrinous exudate, right, on the anterior surface of iris. They start contracting, so pulling the iris in front, right? So that's when you get this eversion of pupillary margin. Okay, then occlusopupillae, right? Next here, what happens? Your pupil is completely occluded with exudates. Okay, seclusopupillae, occlusopupillae, two different things. You must get it right. So seclusopupillae is when the aqueous cannot flow from posterior to anterior chamber due to ring synecdoche. Here, complete occlusion of pupil because of exudates. Clear? Now, why are they very important? Why am I stressing on seclusopupillae and occlusopupillae? Is because this condition can give rise to a complication, that is glaucoma. We will see later. Okay, so this is festooned pupil again. Appreciate it. Ectropion pupillae, try to appreciate it again. Then move on to lens signs and vitreous signs. Now they are not extremely important, but I want you to highlight one thing under lens signs, that is complicated cataract. We'll discuss about this complicated cataract. It's because it's a complication of uveitis. Okay, same like glaucoma. So I've told you two complications. One is glaucoma and one is cataract here. Okay, we'll discuss both of this. So first we will discuss cataract since we are already here. What happens is there's a lot of deposition of exudates of pigments, what happens, you get is a breadcrumb appearance. Remember this, breadcrumb appearance, common MCQ that I was. Okay, breadcrumb appearance seen in, or it's a complication of iridocyclitis. Okay, that's about it. Then move on to complication. Okay, so the first complication is band-shaped keratopathy. Okay, the pathology of the cornea. So there's this band there's this band on the cornea. Okay, it's a complication of this inflammation due to the inflammatory process. What happens to the cornea? There is band formation. Okay, then choroiditis, inflammation of the choroid layer, complicated cataract, as I told you above, right? There's a lot of deposition of the exudates and of the pigments on the lens that give rise to the breadcrumb appearance. Cyclic membrane, this is very important, right? Now let's say if this is lens, right? What happens, right? There is formation of a membrane behind the lens. Okay, it's because of healing by fibrosis. That means the inflammation is healing but by fibrosis, so it forms this membrane, and obviously cyclic membrane would definitely give rise to visual disturbance. Okay, so visual prognosis is poor in this case. Interesting one, secondary glaucoma. Again, there's two types, an early stage and a late stage. The early stage is also known as inflammatory, the late stage is also known as post-inflammatory. So the word inflammatory and post-inflammatory would tell you a lot. So inflammatory, that means it's during inflammation, right? You get this glaucoma. So during inflammation, what happens? There's going to be a lot of inflammatory cells. These inflammatory cells in the aqueous chamber is going to block or clog the trabecular meshwork. So what happens if your trabecular meshwork is clogged? That means clogged, your aqueous drainage is decreased. Okay, when your aqueous drainage decreases, what happens to intraocular pressure? Increase. This gives rise to secondary glaucoma. Simple. Post-inflammatory. Now here is because of pupil blocks. Two types of pupil blocks we saw, occlusopupillae and occlusopupillae. Both of these affects obviously flow from the posterior chamber to anterior chamber. This would give rise to, again, post-inflammatory glaucoma, which is a secondary glaucoma. Okay, band-shaped keratopathy. There is also papillitis. Okay, so what is papillitis? Inflammation of the optic disc. This is interesting. Phthisis bulbi. Okay, here what happens, your ciliary body, right? I'm just trying to draw my ciliary body. They get disorganized, so they are the ones producing your aqueous, right? So aqueous production decreases. If aqueous production decreases, what happens to your eyeball? Shrinks, and you get atrophic globe. This is known as phthisis bulbi. Okay, clear? Next is retinal complications. You can get, okay, cystoid macular edema, exudative retinal detachment, very important this one, and macular degeneration. Okay, now let's talk about the treatment of these complications a little bit. With inflammatory glaucoma, we're going to give timolol maleate 0.5% eye drop, BID, plus acetazolamide, zolamide, 250 mg TID. This is to decrease the intraocular pressure. Simple. Post-inflammatory glaucoma, you're not going to give this timolol maleate and acetazolamide, because now here is not a problem with aqueous drainage but rather a problem with obstruction. So you need to remove this obstruction, am I right? So laser, iridotomy, that means using laser you're going to cut the iris, or if laser is not there, right, then you can do surgical iridectomy, that means cutting off out of the iris. So this would treat occluso and occluso pupillae, right? That's the idea. Okay, that is for secondary glaucoma treatment. Another one, as I told you, that we like to discuss is complicated cataract. In this case, obviously, what? Lens extraction. That's it. Okay. If there is phytitis bulbi, normally it's fine. See, this is how it looks. Phytitis bulbi, it's fine. But if it's painful, then you're going to go for enucleation operation, total removal. Okay. Retinal complications, normally in detachments, okay, you will need to do vitrectomy. Okay, clear? Then we move on to the investigations. So there are n number of investigations actually, so I'm just going to go through them very quickly and you would understand them also. TLC and DLC, literally this is my CBC, right? But so TLC, DLC is to see whether there's inflammation. Erythrocyte sedimentation, really important, is to see the chronicity of the inflammation. You're going to do sugar level, uric acid, this is to rule out diseases. Okay, sugar level to rule out diabetes mellitus, uric acid to rule out gout. Okay. And serological tests, syphilis, histoplasmosis, toxoplasmosis. Okay. So because all of these diseases should be treated separately because they can lead to iridocyclitis. Urine examination, okay, to see whether there's RBC, WBC or pus cells, and all of this is to rule out UTI, importantly. Stool, you want to see whether there's cyst, whether there's ova, to rule out parasitic infestation. Radiology, normally you do X-ray, again to rule out all these granulomatous diseases. Skin test is also normally to rule out granulomatous diseases. Okay, tuberculin test, toxoplasmin test. So now treatment, as you can see, that is non-specific and specific treatment of the cause. Now I'll just talk about this very quickly. What happens is you need to treat. This non-specific therapy alone is not enough, because what does non-specific therapy do? It basically, yes, it eats the uveal inflammation. It that means decreases uveal inflammation, but normally this causes is the one giving rise to the uveal inflammation. So you need to find out. That's the reason we are doing all this investigation: hematological investigation, urine examination, stool examination, radiological investigation, and the skin test is to find out the cause. Because if you treat the cause, the uveal inflammation would decrease. But obviously you also going to give symptomatic non-specific therapy. Okay, so locally what you're going to give, systemically what you're going to give, and what are the physical measure. Okay, so let's talk about locally. You're going to give mydriatic and cyclopelagics normally. So what are the things that you can give? Atropine sulfate, Okay, 1%. Eye drop, TID normally, is also given as eye ointment sometimes. Then cyclopentolate, right, 1%, or homatropine, 2%, also TID can be given, or something more powerful. Normally cyclopentolate and homatropine is given if there's an atropine allergy, or something more powerful you can give is midrikine. It's more powerful cycloplegic, 0.25 ml subcutaneous injection. Okay, all of this is continued for roughly 2 to 3 weeks. Okay, clear? Simple, that is to prevent any relapse. Then you can give corticosteroids, right? So what are the corticosteroids you can give? The list goes: betamethasone, dexamethasone, and prednisolone, the norms. Okay, either drops or ointment. Okay, you also can give subtenon injection, anterior subtenon injection in serious cases lah. Otherwise you stick to drops and ointment. Ointment normally bedtime, drop is in the morning, 4 to 6 times during the day, sorry. Okay, 4 to 6 times a day. Then you can give broad spectrum antibiotics. Now this antibiotics has got no use in uveitis. They do not decrease uveal inflammation, rather they are just for umbrella cover, because you're giving steroids, right? So just in case. Yeah. Why? Because when you give corticosteroid, body's immunity decrease, prone to infection. That's the idea here. Okay, again, that is that. Then systemic therapy, again the same corticosteroids. You're going to give beta, dexa, prednisolone. Now it's normally daily therapy for roughly about 2 weeks. Okay, but alternate day regimen is also fine. Let's say if your disease is not in the acute stage, you can go for alternate day, and after that slowly decrease the dose after 1 week. Okay, slowly decrease the dose after 1 week, and then taper it completely after about 6 weeks. So decrease dose after 1 week, taper it after about 6 weeks. NSAIDs, aspirin, normally when this is given when the corticosteroids are contraindicated. You also can give immunosuppressive drugs, AZT, okay, MTX. Okay, this again is in very serious cases, and chances are, you're going to get blind. Patient's going to get blind, sorry, serious, or patient's going to get blind, or if my steroids are failing, then you go for this. Otherwise, not really. Okay, hot fermentation again is just for its soothing effect. Dark goggles is to basically decrease blepharospasm, the photophobia, and lacrimation. Okay. That's about it. And next, last one, treatment of complication. We have already discussed complicated cataract, lens extraction, inflammatory glaucoma, timolol maleate, and acetazolamide. Post-inflammatory glaucoma, laser iridotomy or surgical iridectomy, petasis bulbi enucleation, retinal detachment, vitrectomy. Okay, thank you for watching.